Well, hello and welcome to the 26th Annual National Health Equity Research Webcast. I'm Leonita Inge, Race and Southern Culture reporter for WUNC, North Carolina Public Radio. I spend a lot of time exploring modern and historical constructs to tell stories of poverty and wealth, health and food culture, education and racial identity. I will be your moderator for today's interactive webinar, where we will discuss this year's theme, Truth to Power, Building Solidarity for Health and Democracy. It's a special day, and just like we're meeting today virtually, many more people are gathering virtually for the national observance of September 11th, where the names of the tragic victims of that terrorist attack are being read today. On behalf of this year's organizers and sponsors, I would like to welcome everyone joining us online from across and outside the United States. Closed captioning is available during the webinar and can be turned on at the bottom of your screen. Before I introduce our panelists, I would like to recognize several of the many organizations and individuals who have made today's webinar possible. We extend a special thanks to our leading co-sponsors, the UNC Gillings School of Global Public Health, led by Dean Barbara Reimer, the UNC Center for Health Equity Research, led by Dr. Giselle Corby-Smith, the UNC Office of the Vice Chancellor for Research, led by Vice Chancellor Terry Magnuson, and North Carolina Area Health Education Center, AHEC, led by Hugh Tilson. For several decades, UNC School of Public Health has been committed to groundbreaking research, exceptional teaching, and dedicated service to people across North Carolina, the United States, and around the world. This marks the 26th year of the school's sponsorship of this annual broadcast as we continue addressing issues within health disparities. So it's my pleasure now to turn the floor over to Dean Barbara Reimer from the UNC Gillings School of Global Public Health with today's welcome.
Thank you so much, Leonita. It's a pleasure to welcome you all to the 26th National Health Equity Research Webcast. Thank you for joining us today, and thank you especially to all the people who planned this event. And I'm going to read their names in alphabetical order, and please join me in virtually applauding Colleen Cipriani, Elizabeth French, Kiana Jones, who chaired the committee, Derek Matthews, O.J. McGee, Yesenia Marino, Rachel Quinto, Dana Rice, Brooke Staley, Rachel Wilford. And special thanks to Derek Matthews, Yesenia Marino, and Dana Rice for connecting us with our distinguished panelists, and to O.J. McGee and his team of AV specialists. Thank you. You have made this webcast better and better every year. Shortly, Leonita Inge will introduce our impressive panelists, but I also want to note that our audience includes scholars, teachers, community leaders, students, and public health and healthcare practitioners and researchers from across the country and beyond. And each year's programs are archived and available for free on the website for the National Health Equity Research Webcast. Thank you, Leonita, for being our moderator. I always look forward to your stories on WUNC, my station, of course. Thank you for your outstanding reporting on race, culture, poverty, justice, and health inequities in the South. Your reporting gives voice to those who otherwise might not be heard. This year's theme is perfectly aligned with the times, when so many of us feel that the very foundation of our democracy is at stake. Health, public health, and democracy are intertwined at every level, from the community and country to the state, nation, and world. The roots of democracy and public are in people, and the notion that people have a say in government. They must have the right to vote, the means to vote, and then act on that to vote. So for example, if it has occasionally happened, if people theoretically have the right to vote, but the closest polling station is 100 miles away and requires waiting in line for 5 hours, that is not a practical reality. But if we have the right to vote and the means to vote and don't vote, then shame on us, because we are going to live with the consequences. Public health is very much about the health of people, just as democracy is about people. Ed McGavran, a former dean of the school, referred to public health in terms of the body politic, thinking about the health of all the people, but how connected that is to politics and to the school's embeddedness in local communities. As public health professionals, we are about the people, connected to the people, and concepts of democracy are woven through how we do our work on every level. At this school, where we have been developers and proponents of community-based participatory research, we apply concepts of governance to how we work and interact with communities. Voting is inherently connected to public health because who leads has a lot to do with how healthy people are, especially the most vulnerable among us. Today, public health is more relevant and important than ever. It sits squarely at the intersection of three massive phenomena that are roiling the world: the global pandemic, the recognition of racial inequities and demands appropriately for an end to racism, and the economic consequences that are fraying lives across North Carolina and around the world. The American Public Health Association declared racism a public health emergency. Racism causes ill health and deaths disproportionately in those who experience it. Democracy holds one of the critical keys to the path forward, and that is free elections. In the November election that's coming up, voters can decide what kind of America they want to live in. One that has a big tent and a big heart, that values every person and is committed to equity, justice, fairness, and respect, where everyone can thrive, where good education, clean water, sanitation, and quality health care are regarded as rights and not privileges, where investment in public health is policy, and where racism and racist policies no longer have a place. That America will be a healthier America. Or voters can choose a different America, where the color of one's skin, where one lives, and how much money one has may determine who lives and who dies, who gets a quality education and who does not, who gets jobs and who does not, who gets health care and who does not, who gets justice and who goes to prison. These are stark differences, and because they are tied so closely to the health of populations, they are public health concerns. I am a public employee, and I cannot tell you for whom to vote, but I can urge you to get ready to vote, to be sure you are registered in the district where you live, and have a plan for how and for whom you will vote, not just at the top of the ballot, but all the way down. And consider volunteering at the polls. They need you this year. This is not an election to sit out. The results may affect the quality of public health, the economy, and our collective well-being for years to come. This year's webcast theme of building solidarity for health and democracy could not be more urgent. We have an opportunity now to stand up for democracy and the values we in public health embrace. We can achieve the American ideals embodied in the US Constitution of being America for all, and not only America for the privileged elite. That is a weighty responsibility with which we are charged, but we are worthy of that responsibility. I'm sure you are as excited as I am to hear from the speakers and to be inspired by them. Thank you for your joining and your commitment to health equity and democracy in our communities, our country, and the world. And now I will turn this back over to Leonida. Thank you, and thank you, Leonida.
Well, thank you so much, Dean Reimer, for those remarks. And it's really amazing that the times we're living in right now, when one's health is really directly related, one's health during this pandemic is directly related on if that person will get to vote or not. It's a topic of the times, and it's a topic of right now. And this conference, this gathering, is even more pertinent at this hour. So, well, now it's time to briefly introduce our panelists. Our first presenter is Amanda Navarro. Amanda Navarro is the Chief Impact Officer at PolicyLink, a national research and action institute advancing racial and economic equity. Dr. Navarro helped shape the organization's strategic direction, which includes the Convergence Partnership, a collaborative of foundations and healthcare institutions working to make lives better for children and families. Before joining PolicyLink, she worked at the U.S. Centers for Disease Control and Prevention, coordinating several programmatic and research activities related to racial and ethnic health inequities, social determinants of health, and community health promotion. Our second presenter is Mia Keys. Mia R. Keys is the Director of Health and Equity Policy and Advocacy at the American Medical Association. She formerly served as the Policy Director of Congresswoman Robin Kelly's Congressional Black Caucus Health Brain Trust, the premier health policy arm of the CBC. In April 2017, the National Minority Equality Forum recognized Ms. Keys as a 40 under 40 leader in minority health. The Institute of Medicine, National Academy of Sciences features Ms. Keys' children's book on health equity titled Cold Blue, Full of Valor in its National Archives. And our third and final presenter is Anita Chandra. Anita Chandra is Vice President and Director of RAND Social and Economic Wellbeing and is a Senior Policy Researcher at the RAND Corporation. Her division also manages RAND Center to Advance Racial Equity Policy. Dr. Chandra leads several studies, including civic well-being and urban planning, community resilience and long-term disaster recovery, and public health emergency preparedness. Throughout her career, Dr. Chandra has focused on health and human service systems and how to integrate equity and address the needs of historically marginalized populations in those systems. A huge welcome to our distinguished panelists. Each panelist will make a 10-minute presentation. Following the presentations, we will engage in a question and answer session, so please submit your questions in the Q&A chat throughout the webinar. You may also ask questions by Twitter or Facebook at any time. The Twitter hashtag is #NHERW So without further ado, we will now hear from our first panelist, Dr. Amanda Navarro.
Thank you, Leonida, so much, and thank you to the UNC Gilling School of Global Public Health for inviting me to join you today. I'm happy to have this opportunity to be with all of you through the Zoom ether, and also in being in company with my esteemed peers, Anita and Mia. So as we have heard and will say again, today's topic is really a timely one. This country finds itself once again at a moment of reckoning in its fight for equity and justice and true democracy. And today I'm going to take my time to talk a little bit about the importance of really looking at the connections between democracy, equity, and power as it relates to health, but also really giving some food for thought around what it's really going to take for us to win on equity. Next slide, please. So as mentioned, PolicyLink is a national research and action institute. We advance racial and economic equity by lifting up what works. PolicyLink ensures that all people, particularly those who face the burdens of structural racism, participate in a just society, live in a healthy community of opportunity, and prosper in an equitable economy. And we are focusing on advancing liberating policies for the 100 million people living in or near poverty, the majority of whom are our people of color. Next slide, please. So PolicyLink, the way that we define equity is just and fair inclusion into a society in which all can participate, prosper, and reach their full potential. But as we also know, part of what equity is, it's not just the end, it's also the means. And the fundamental questions that we must ask ourselves in every decision that we make and choice that we make about our work is, who's really benefiting from what we are choosing to do? Who decides? Who's in ownership and control of this decision, and who will be paid or harmed? But also, who is leading and governing, and who is missing from these decisions? Next slide, please. So this timeline, I apologize, it's a little small. I hope you will go to the source, and the link is there on the slide. This timeline shows all of the policies and rules and regulations that have either boosted equity or blocked it. And historically, more has been done to block it than boost it. But it also illuminates the role that policies play in driving what we're currently seeing as racial and health inequities that we're facing. So when we examine history, we must pay close attention to the fundamental role that government policies are playing in the distribution of power and resources. I'm also sharing this specifically to point out that while the social determinants of health is a widely accepted concept in our field with in other sectors and with policymakers, that health inequities are shaped by community conditions such as transportation, access to healthy food, housing, prevention and healthcare, and many more. We fall short of really having a deeper inquiry in asking, if these determinants shape health, then what shapes and creates these determinants? And that is why we have to start thinking about the political roots of these determinants of health. Daniel Dawes just actually came out with a book called The Political Determinants of Health, and I strongly recommend for you all to read it. And in his book, he focuses on 3 specific political determinants of health: voting, government, and policy. And he explains how each of them individually and collectively are responsible for producing and sustaining the inequities in our society. So it really is our work now to acknowledge those political forces and political choices that have affected the nation's health, and to begin to connect the dots between voting, government, and policy in support of equity across the country. So in examining our history, we're also seeing that there are political choices that shape the rules of the world today. And what we're seeing is that when you take a deeper look at these policies and practices, that it's evident that racism is embedded in them. So we should not be dismissing racism or even reducing it as a factor, but rather seeing it as it being deployed strategically as a default practice to undercut democracy. And you'll see that these 4 book covers really are a very deep dive into how racism has been embedded in various sectors and policies around housing, medicine, public health, and the criminal justice system. Next slide, please. But I also want to honor the fact that we've also seen in history movements that have really promoted transformative change, whether it's the women's suffrage movement, the civil rights movement, the gay rights movement, or resistance against apartheid. We really are being held up by the strength and the dedication marked by the incredible efforts of these courageous leaders. And so here are some of the most important social movements of the last 100 years. But I really want to point out that what is so unique about this moment is what we're witnessing, as movement leader Reverend William Barber calls it, the third Reconstruction. And it's the movement that is really unlocking the deeper consciousness of how the issues of race, class, age, and gender intersect, and that we must really acknowledge that the new movement to win on equity must work on all fronts and must be intentionally intersectional. Next slide. So the way that we're thinking about at PolicyLink, what are the critical structural barriers that we must dismantle to win on equity? There are several. And ultimately, what we're really trying to do is to begin to repair and bolster democracy and really show the interconnectedness of implicit bias, structural racism, and capitalism in driving these negative outcomes for the 100 million. But more specifically, we must be able to start confronting the concentration of wealth and power, begin to start bolstering the expression of people's will to vote, and will through voting, as well as participating in democratic processes, begin to really dismantle the privatization of public goods and services, and also really starting to tackle the major issue around automation and the potential of displacement of hundreds of people on their jobs. And last but not least, that we really begin to start confronting the deeply entrenched racialized narratives that are undermining the inclusion and belonging and dignity of all people. Next slide. So what we're really looking to do at PolicyLink is, and that we're reflecting on our accomplishments over the last 22 years, is that we recognize that we must lay bolder ideas for dismantling the current structures that are holding the 100 million people back. And what this really means is that as we chart the new course and to achieve our result, we're really looking to focus on 3 levers of change. The first is to reform democracy, and also the second is to shift dominant ideology. And that is really focusing on making sure that we empower the people, that we begin to create and master a democratic governance, and we also begin to mitigate the anti-democratic structure that was built in this country. And then more specifically, the bold innovations that we're really looking at around issues, we're focusing our work around housing, community safety and justice, and water equity and climate resilience issues. Next slide, please. But in the most immediate, in the specific response to the pandemic, we've released a set of principles that we've shared with various practitioners and advocates and elected officials, and we're seeing really the uptake of these that has been quite promising. But we really do believe that in order to realize the promise of equity, we must dedicate our work to the full set of principles around centering racial equity, putting people first, investing in community infrastructure, building an equitable economy, and protecting and expanding community power and voice. Next slide, please. And while I'm not going to go through all of these, I just want to really focus on the last one around community power and voice. And in times of disaster, and we're actually seeing it now, is that state and local leaders forego community engagement for the sake of expediency. But this is the exact moment when it is more important than ever for community and grassroots leaders to be the agents and the owners of that change and to create and lead on the solutions. We must also do everything to protect our right to vote. And because of the array of discriminatory laws and practices, such as voter ID laws, restricting access to polling places, and many others that we're seeing now, even in the lack of support of the US Postal Service, those are really creating major barriers for people of color to exercise their right to vote. So it really is on us to push our government, state, county, and city leaders to make sure that no voter is disenfranchised due to this public health crisis. And then last but not least, we must also make sure that frontline workers that we know and are recognizing are essential for the economic stability and viability and health of this country. They are disproportionately people of color and women, and they must be able to have the opportunity to exercise their right to organize and to collectively bargain, and to also be protected in their health and well-being. Next slide, please. So what has been most, and what I see as a bright spot in all of this, has been the incredible movement within the public health field. And in this awakening, we're seeing now that 20 cities and counties, and I think at least 3 states, have declared racism as a public health crisis. And these declarations are so important to help to spur change. And we must be able to support our leaders in making sure that they're also prescribing specific policy actions and putting dollars into making investments to making sure that these declarations become realized. And then in the corner, you'll see the Public Health Code of Ethics. And what I think is so also very promising and wonderful to see is the American Public Health Association just came out with a revised Public Health Code of Ethics. This is their 2019 version that includes ethical standards around health justice and equity, interdependence and solidarity, and human rights and civil liberties. So I encourage all of you to take a look at that. Next slide. So last but not least, what will it take? Well, first, I think it takes that we can no longer tinker on the edges of health equity, and we must go beyond the social determinants of health to really look at the political roots of health. We must also make visible what's invisible and speak out and advocate and champion for the policy changes that we want to see, as well as be supportive of intersectional movement building in our movement leaders. But we must also confront the threat of the continuation of othering of people, and that how that is fueling violence and social division and segregation. We must acknowledge that whiteness and white supremacy has thwarted so many to not experience health and well-being. And just on a soul level, to subscribe to whiteness requires you to defend and deny and disassociate, and there is no peace or health or wellness in that. We must also learn to begin to shift and share our power. And I know from a public health perspective, you know, we are seen as the expert. We must also honor that the experts are those that are living day to day in the struggles of really ensuring opportunity and well-being for themselves and their family. We must know when to step up, but also when to step aside for others to lead and speak. We must keep our eye on the big money. Budgets are more than numbers. They're a social contract that reflect our moral priorities and values. The budget cutbacks and the lack of investment that we're seeing is at a time when we really do need more equitable investments and really a need to invest in when we know what works in community infrastructure. And then last but not least, to just share that we must work on our own biases and assumptions. To quote Angela Davis, in a racist society, it is not enough to be non-racist. We must be anti-racist. We have to be honest with ourselves about the past and the present, or our future will not look any different. We have to decenter whiteness in our institutions and our disciplines. And I will end with a quote. So before Dr. King was assassinated, he was preparing a sermon that was entitled, Why America May Go to Hell. And in those notes that were found, while he wasn't able to preach this sermon, he left us with this note. Now more than ever before, America's challenged to realize its dream, for the shape of the world today does not permit our nation the luxury of an anemic democracy. And the price that America must pay for the continued oppression of the African American and other minority groups is the price of its own destruction. For the hour is late and the clock of destiny is ticking out. We must act now before it is too late. Thank you so much.
Well, thank you very much, Amanda. And repairing democracy, that's a big one. Hopefully that will happen in our lifetime. But one thing we know that is happening and that is that people are really feeling empowered during this time. And that's something hopefully will continue. We will now hear from Mia Keys. Mia.
Thank you, Leonida, and thank you very much to the entire UNC team for putting together this incredible webcast. And I'm really glad to be here with Amanda and also with Anita. And glad that I'm following up with behind Amanda. I think I can expand on some of the things that she mentioned. And so we're going to together, and I'm going to offer a commentary on equity, on anti-racism, on policy and public health leadership. And so I'm really excited that you all are attending and in the audience. So let's just go ahead and get into it. Next slide, please. So, you know, we're veritably at war to save lives within this pandemic crisis. And from an equity perspective, we're especially battling against the social as well as the structural and the political conditions, which Amanda alluded to, and which marginalized and minoritized communities face and bear inequitably on their health outcomes, on our health outcomes. And so to do so, to really build out this conversation, these are the three key tenets and three elements that I'm imploring us to employ, right? So one, our tactics and our strategies as researchers, as academicians, as scientists, as leaders in public health must be grounded in health equity, and we'll talk more about that. But really what I mean is intentionally striving to deeply and more appreciatively understand the power of federal policy as it bears on your and our ability to exercise and make healthy choices through exercising democratic rights and benefiting from the overall democratic process, right? But then I'd also implore us to take up our own mantle as public health leaders who are advocates for health equity, meaning this applies to taking a deep review of our own organizational policies, our university's research practices as it relates to centering equity and what that means in bench science, what that means in public health related research, and explicitly applying an anti-racist lens throughout all of your work, all of our work. And then finally, the last tenet that we'll speak about today is actualizing equity and anti-racism in public health and through your leadership, and embracing structurally competent leadership as a core tenet of our well-being. Next slide, please. So what this unusual moment of pandemic and really syndemic and any public health crisis demonstrates is the need for public health, medicine, and science leaders to assume larger structural systems and policies engagement, right? And it's not sufficient to merely operate within your sphere of influence in a silo, right? And so the most optimal way to engage and to do this is via an application of an equity lens. As Amanda alluded, equity is in its own nature intersectional, and it moves us from individual level of risk factors through to discussing social determinants of health. But as she mentioned, we can't stop there. We have to go to a more upstream root cause of health, and a major part of that is going to be a bulk of our conversation later on around policy. But I first want to ground us in some language. And I want to make sure that we walk away with a firm understanding, again, of what equity is and what anti-racism is and why it relates to this conversation. And so Amanda introduced it and mentioned, equity is about being just and being fair, right? I want to talk about what equity is not, so that we're not conflating our language. Equity is not equality. Equality is the philosophy of to each the same, right? And that's the experience that you see here within picture one. And according to the World Health Organization, more specifically, equity is the absence of avoidable or remedial differences amongst groups of people, whether those groups are defined socially, economically, demographically, geographically, so on and so forth. And the opposite of equity in this case is inequity. And the CDC notes that inequities are a type of unfair health difference or differences that are closely linked, again, with those social, economic, and or environmental disadvantages that adversely affect groups of people. And so basically equity is the process that considers structural barriers, which are not initially under people's individual control, right? And equity helps to create pathways so people receive what they need for an optimal experience across the life course. So in essence, equity is the philosophy of to each according to their need, right? Compared to equality, which is to each the same. And that's the experience here of equity that we're seeing here within picture two. I want to also offer a definition of anti-racism, right? So, and Amanda mentioned in her talk, she said it's not enough to be non-racist, right? We really do have to assume a posture of anti-racism. Being anti-racist necessitates that institutions, and people make up institutions, that institutions challenge structural racism and other intersecting oppressive systems, right? And that could be heterosexism, classism, ableism, ageism, so on and so forth, by shifting power. And ways that you can demonstrate within your own institutions a shift in power is through funding, evaluating funding and other critical resources, really doing a deep dive into policies and processes such that you can apply an equitable lens into how those play out and work on the culture across the organization. looking at leadership and who sits at tables where decisions are made and who's a part of those decision-making processes consistently, and overall evaluating culture. And this is so that we may all, and especially marginalized and minoritized peoples in the US, may live and thrive in a healthy way in this country, right? Structural racism, I must say, also refers to the totality of ways in which societies overall foster racial discrimination through mutually reinforcing systems, right? And that's included within the healthcare system. Yet there are vast differences between experiences of groups that for a long time have experienced advantage and the experiences of marginalized and minoritized groups that for a long time have experienced disadvantage. And this is what we see in reality within picture 3, the depiction there. I must say that in a perfect world, we would all be liberated from these barriers that keep us apart and that render certain life experiences unattainable, but we're not yet there. This is the war, and that's the battle. And if we win this battle of really understanding what equity is and how it operates and what anti-racism is and how that operates within our spheres of influence and beyond, then we will eventually, and I hope, and also strategically move toward this idea of liberation, and that's what we see again in the last picture. So the other thing is about why equity matters, aside from it being a moral imperative, why anti-racism matters, is because it impacts how resources overall are distributed. It impacts how and who the people are who come to power to decide on how those resources are moved and distributed, right? And in the context of health, the AMA considers equity to mean optimal health for all. And health equity specifically determines access to comprehensive clinical services, to social needs, including safe and affordable housing, reliable transportation, fresh foods, clean water, educational and economic opportunities, telehealth access via uninterrupted broadband, and overall impacts longevity of life. And equity in these areas is achieved through social wellness movements, through health advocacy, through health policies that embed equity at its core, all activities that you can do alongside the work that you move as researchers, as public health leaders. None of that is mutually exclusive. In fact, they need to be elevated and incorporated on a consistent level. But what does it mean, and what do I mean when I say that equity ought to be embedded into our health policies? And if not, then there are serious consequences, which ultimately determine how physicians deliver care, how public health practitioners move forward with respect to interventions, how policymakers are able to introduce laws and so on and so forth that play on our daily life. And I guess a more granular question would be, what does it mean to embed equity into the very practice of medicine, into public health work and research, right? And so to understand this, I do, this policy and practice embeddedness dimension of equity, we must foremost appreciate the extent to which our nation's overall policy history bears on our health, right? By examining policies that aren't grounded in equity. And so I want us to do that. We're going to do that together. Amanda laid out that Booth's graphic. And so what I'm going to do is we're going to move to the next slide, and we're going to walk through some of those things that many of us might be familiar with, but perhaps on a daily basis, we don't necessarily take the time to really make a connection to why things that have happened in the past impact us today and ongoing. If we do not remedy them with policy, with science, then we're going to 100 years from now, someone's going to have a similar conversation and look back and say, well, we missed the moment. So the first policy milestone or major event that I want to talk about is the 1830 Indian Removal Act, right? And so this was an act of government. This is prior to the U.S. becoming an actual country, but still governing. There was a governance body for sure in place. This act essentially removed Eastern indigenous peoples to the West to make room for white settlers, right? And I do not mean to make light of this, but for the sake of time, we're going to move relatively quickly, but I will pause to say that the trauma associated with just this act alone has completely reverberated with respect to the health of indigenous peoples and all those who also are in contact with communities that are indigenous and have family members who are also within these communities, right? We might colloquially know this act as the Trail of Tears, right? And so what happened in several years later is the Homestead Act, where white settlers were given those lands, 160 acres worth of land specifically, to move, to build community, to sustain their families, and to eventually build wealth. Because we do know to this day, when you're talking about wealth building, you absolutely have to talk about land ownership and property and so on and so forth. And then just a couple years later, we come into the end of the Civil War. And at this point, slavery is abolished, right? We didn't even talk and touch about what was going on in the 17th century, but we all know what happened. And so then after the abolition of slavery, we have this period of Reconstruction. And within that time, there was also Black men were afforded the right to vote. But we do know that that was not a one and done deal, right? We still, and Amanda has already told us, we still struggle with protecting the right to vote. And extending access to the ballot is absolutely a public health, and it must be a public health priority. Next, please. And two after that. And so, again, so Reconstruction goes on until 1877. And this is, you can just ignore the fact that I have 1910 behind 1877. But basically, I do want to talk briefly, since we're referring to public health and also to medicine, the Flexner Report. If you're not familiar with the Flexner Report, I highly suggest that you go and familiarize yourself with it. It essentially changed the way that medicine is practiced and that medicine is taught. But what happened with the Flexner Report, which was commissioned by the AMA, I will say one of the councils in the AMA, is that it closed a number of minority serving institutions and medical schools for women, and medical schools that were deemed for Black and brown physicians. And so when you're talking about what that means in terms of access to care, that implicates who can be licensed as physicians. It implicates who's in what spaces to provide care, and we still deal with that issue today. Next, please. And then so after this point, we're coming now into a space of war and tumult across the world, right? And also another pandemic, well, rather a pandemic that preceded the one that we're living through now, the Spanish flu, colloquially. Right, and we can't. Yeah, Lenita, you're shaking your head there, right? It's for us, to have that conversation when we're talking about who's impacted by COVID-19. It's a similar conversation that we could have with prior things that happened in the past with respect to pandemics. Those who are most vulnerable, those communities have not changed, right? We've not yet dealt with that consistently. So you can hit it two more times after this, please. So now we're getting into the 1930s, and we're coming into the Roosevelt era, right? The era of the New Deal. And the thing about the Roosevelt era is that there's so many innovative policies that came out at this time, right? We can look at the New Deal overall, the Federal Housing Administration, which provided low-cost housing loans for working-class families. That's epic. That's really what started to build up the American middle class. But the thing about the loans, the eligibility criteria were delimited by race, such that we then have a phenomenon of redlining coming up. And I know Amanda showed you that Rothstein book, The Color of Law. If you haven't yet read it, certainly do so. And you can learn even more about decades of segregated neighborhoods that really came out of this New Deal policy, right? And then another policy that came out of Roosevelt's time has to do with Social Security and ensuring that in elder age, you can take care of yourself and you don't have to completely depend on one family. But the thing about the Social Security Act is that everyone received it except for agricultural workers and domestic servants. Now, historically in our nation, Black and brown people are agricultural work, or are the ones who are predominantly agricultural workers and domestic servants. And so you can certainly make that connection for yourselves in terms of what that means ongoing and not just in the moment, right? So following the Roosevelt years, we're now coming into another war, and then another war after that. I'm sure many of you, including myself, have had grandparents who have either fought in the Vietnam War or have had a lot of stories around that. And we can have an entire conversation about what it means to be a soldier and then come home to a country that may or may not really be taking care of your unique needs as someone who stood up for your country. But I won't get into that for the sake of time. But then we come into the 1960s, and we're now moving through the civil rights era, right? And so we're just coming off of August, where we're celebrating the 57th anniversary of the March on Washington, which is just down the street from me. I'm sitting in DC. And I can't help but to think about leaders in the policy space, such as John Lewis, who as a young man stood in front of thousands of people and really helped to move this needle of this era that we now look upon and really are thoughtful about. But the beautiful thing about the civil rights era with respect to medicine is that it authorized the feds to really enforce desegregation in public health, in public spaces, right? Then the Voting Rights Act passed, and then, next please, and then Lyndon Johnson signs Medicare and Medicaid into law, right? Which of course expanded access to care in a way that had never happened before. I will say, because I do represent the AMA, and I wouldn't be transparent if I didn't acknowledge that initially the AMA was not on the side of Medicare and Medicaid. The organization did not support the expansion of care for those who were previously uninsured. And of course, we've come a long way since then for a number of reasons. And so now we're getting into the 1980s. And by the way, this is not an exhaustive list. There's so many other things I could have talked about, but when we're talking about equity, and to get at Amanda's point about intersectionality, I really also wanted to bring in the immigration conversation, right? Because our nation is burgeoning with respect to who is calling this place home, right? And the Immigration Reform and Control Act really reestablished the ways in which those who are immigrating to the nation are able to access residency in the country. And we'd have to really pick that apart to understand what the ramifications are. And then also several years later, with the Americans with Disabilities Act, now we're seeing this more inclusive conversation of those who are disabled, or other people might use the language differently able-bodied, but I prefer to use disabled right now. Now we're having conversations where we can say, okay, well, what does it mean for us to recognize those who are disabled in this nation in terms of making sure that people can access sidewalks, get into buildings, and all of that is not confined. The benefits of that policy are not confined to those who are disabled. We all benefit from sidewalks and elevators and so on and so forth. And then we get into the Clinton era, and we have the Welfare Reform Act. I can wax poetic about what it means to consider this ideal of the American dream and individualism and personal responsibility, but then also talk about the responsibility of the nation to really take care of its people, and whom for a long time have not been well, right? And then we get in, of course, into the era of additional expansion beyond the what Medicare and Medicaid did. And the Patient Protection and Affordable Care Act certainly expanded access to care in a way that that had not happened since the 1960s. And then we started seeing erosion of some of the main tenets, and that's problematic. Now that we're in the period of COVID-19, we have to be even more thoughtful about what's going to happen moving forward, right? And so I say all that to say, and again, I could have added so much, and I know that was a lot in a little bit of time, but as public health, medicine, and science research experts, none of us can afford to not know to really not to be ahistorical, or to not completely understand how the trajectory of our national policies have simultaneously catapulted some communities into realities that lend well to wellness, to wealth, to opportunity, while for racially minoritized and marginalized communities, and for those who are religious minorities, those who are disabled, those who are gender minorities, how a lot of these laws have not had those populations in mind, and therefore resources that were associated with these policies had not been distributed or within the same reach, right? And so I'll actually stop here with that slide, and we'll go on to the next one and talk about some things that are going on at the AMA. So as I mentioned, the AMA has not always been on the right side of policy with respect to acknowledging health inequities and disparities, and that has changed over time. It's been a long time coming, and I can tell you all the things that led up to that, but where I'll start right now is in June of 2 years ago, the Board of Trustees, because the AMA is run like a little Congress, right? And so all of the policies that govern the ways in which physicians deliver care are determined by the House of Delegates. And so the House of Delegates said, all right, listen, we have got to do something about health inequities. And so they approved a policy that birthed this Center for Health Equity and brought in my direct boss, Dr. Aletha Maybank, who's fantastic. And we've been online now since April 2019. And I actually came on board a year ago, 2 days ago. So I'm celebrating my first year anniversary. Yeah, this weekend I'll do that in earnest. Next slide, for sure. And so our mission and values are really embedded in normalizing equity, and we have 5 strategic approaches, but for the sake of time, I can share those with you another time. Next slide. But I do want to talk about our and the next slide after this. I do want to talk very briefly about that last tenet, right? Because I told you I wanted to talk about equity and anti-racism, talk about what policy and democracy, and then also really drive home the significance of being and taking up your mantle as public health leaders, and what that means. And the way I want to do that really quickly is to show you what we're doing at the AMA through our Center for Health Equity, which is moving our impact such that we are able to do 3 things. 1, improve health outcomes. 2, close gaps and disparities in health outcomes. And then 3, really ensure that whatever we do doesn't further harm that's already been done, right? And does no harm, right? So it's 2-pronged. Next slide. And there's some things that we're doing through there, but because I work primarily in the advocacy and in the policy spaces, that's really where my sweet spot is. And so over time, because this is going to be a really long time commitment to move for transformation within the organizational space. It's not something that's going to happen overnight, but we're really leveraging policy, both internal policy and then working with legislatures and policymakers on the outside to ensure that whatever we put our name on as AMA, we're really able to move the equity needle forward. That is the imperative, that is our strategy. Next slide. And I think there's just 1 more or 2 more after this. Just some of the ways that we're making equity actionable since the center has come online is several things. We have an AMA Center for Health Equity online resource page, which I certainly encourage all of you to go in and take a look at. We're conducting surveys across the nation of Black, Indigenous, people of color who are also physicians. We're making sure that we're engaging with partners who are traditional partners of the AMA and also those who are non-traditional partners, right? So people who are within the health space, the public health spaces, but maybe they're just in the social justice realm, but we need to be in touch with them. And so we're really generating major traction in that way and forming and collaborating authentic relationships with those who are able to help us to do that work. The AMA for the first time has made a strong statement against racism, against xenophobia, and against also police brutality as a threat to public health. And that's huge for such an incredible organization, you know. And then we're doing a number of other things that are specific to our advocacy unit, which is where I primarily work amongst our lobbyists, those who stomp the hill, those who you'll see in state legislatures, those who you'll see, no, they don't, but we can talk about that. That was a great question, by the way. And there are other things that we are looking to do, but a lot of it starts at home. And so even just yesterday, we embarked on a pretty much an all-day workshop where we were working with our lobbying team to really tease out what does it mean to lead with an equity mindset as a lobbyist, as an advocate, and really dealing with the hard issue, right? It's not easy work. I don't sleep it takes a while for me to turn my mind off at night, to think through the ways that we can really get the needle moving with respect to policy. Next slide. But I do want to just mention some things that you all can do as researchers and those who are involved in medicine. There are ways that you can evaluate your annual budgeting. Where are you putting your monies in terms of recruitment and hiring and retention? In departments of equity, right? What does that look like to establish leaders who are able to bring the equity lens across all of the work? What about research, pathways programming? There's a lot of efforts right now, of course, in this next frontier of medicine around augmented intelligence. What about anti-racism applications in there? Structural competency building throughout medical schools, throughout research institutions. What do your public health partnerships look like? With whom are you talking? In what ways are your organizations revisiting documents that really lend themselves inequitably to to research and the way that medicine's practiced, the way that public health is practiced, and revisiting all of that. But really just putting your money where your mouth is with respect to really centering equity into your work. Next slide. Okay, so, I will end on this note. I'm a Philly girl at heart. My mother, both of my parents are nurses. My mother has a doctorate in nursing. My father is actually, he's a scientist and he's retired now. But when I think about what the equity imperative means, and what it means if we don't really take it to heart, it means that people like my mother will always have to show up in all of her PPE when engaging with her patients, right? It means that we as people will be forever changed if we, in a way that maybe that humanity is not embraced and we're not valuing others, if we do not really consider beyond the imperative, beyond the nicety of equity, what it means to really value others. And by leading with an equity lens, that's essentially what we're saying that we're committing to, the valuing of us as well as others, and to each according to their need. So I'll stop there. I appreciate you all giving me attention and giving us attention. And I look forward to questions. And I'll hand back over to Leonida so she can bring Anita into the conversation.
Well, thank you so much, Mia, for your insights and comments on, you said, the social, structural, and political war that many are fighting during this time of pandemic and racial reckoning. And I'm actually very glad to see your face at the American Medical Association. I'm not that old, but I remember growing up with several health professionals in my family, including my father. And one thing that I always knew, if the organization in health care started with American, that they were white, and because they didn't allow doctors and pharmacists and nurses and the like of color to be in that organization. Because I remember I used to go to the conventions of the National Pharmaceutical Association, the National Medical Association, the national nurses. So it is really great to see you at the
And those
American.
organizations were born because the AMA, to your point, barred membership. Yeah.
I know. Yeah, that's why I used to go to those conventions with my family, from a very little girl. So again, it was glad to see where you are right now. Well, our final presentation will be made by Dr. Anita Chandra. Thank you very much, Anita.
Thank you, Leonida. And it's really been a pleasure to listen to Amanda and Mia and build on the excellent presentations that they presented and offered in terms of the foundational work with respect to equity and anti-racism, the opportunities for the future in terms of policies and leadership, and what we all need to do going forward. It's also an honor to be presenting to this webcast because Carolina and the School of Public Health is my alma mater, as well as North Carolina is my home state. So I'm really honored to be with you all today. I'm going to try and move relatively quickly, knowing that we want to leave time for comments and discussion and questions. But I'm going to principally build on some of the comments that Amanda and Mia offered and put it into a larger frame about where we might be going in terms of this theme of health and democracy, what it really means to start to construct this health and well-being narrative going forward. And a lot of my comments are directed to not only public health professionals in the field at large, but what is it going to take to really and truly build a system for health that centers equity, but also is about health and well-being over the long term? And we'll get into it in the next few slides. Next slide. So as our team builds this out for me, I want to kind of recenter not only the field of public health, but the systems for health, and including our medical colleagues and others who've been working in health for several decades. And I think it's important to know that before we encounter this triple pandemic, or at least the recent disruption of this triple pandemic in terms of systemic inequities, a reckoning around race, police brutality, economic opportunity, and COVID-19, we had been talking for some time that were 4 trends in health that were aligning. More and more, we were talking about cross-sector collaborations in health. We were talking about health in all policies, health in all decisions, the importance that health is not just under the responsibility of the public health department or the hospital or healthcare system, but that it must be embraced by all. There was increasingly a greater focus on holistic health, meaning physical, emotional, spiritual health, and a greater focus on well-being. As you heard from my colleagues, Amanda and Mia, a move from not just thinking about closing gaps and disparities, but a way of thinking about structural, social, and political determinants, a way of thinking about equity and what it meant to really get to the people with the services and resources and assets and power that they need based in history, structure, and context. And we were talking a lot about the integration of health investments, how much we were spending, what was the return on the investment in terms of our public health dollars, our healthcare dollars, our broader health dollars. And through all of this, if we just click one more time, there were new conversations that were emerging about, are we just talking about a disease model in terms of mitigating disease, or are we actually talking about what produces health? And this is not just important in terms of creating a healthier nation, one that is socially and economically and civically productive, as the theme of our discussion today suggests, but this is central when we start talking about health equity. It's simply not enough to close gaps with respect to disparities when we're talking about civic power, civic health engagement, and the accumulation of what I'll talk about later in terms of health wealth. When we talk about historically marginalized communities, particularly communities of color, we often have very much a deficit model. We're not thinking about intergenerational transmission of health. We're not thinking holistically about health and well-being. And we were at least starting to have this conversation in the field of health and public health specifically. Next slide. The other thing that was happening, which really builds on Amanda's point around social mobilization, is that colleagues in the UK and in the European Union, as well as colleagues here in the United States and in Canada and other countries globally, we're starting to have a reckoning about where we were as a field, particularly in public health. This is a classic figure that shows the waves of public health, starting with our roots and origins in hygiene in public health, as many of you know. How do we improve the structural conditions of public health? Over the years, we had biomedical advances and clinical advances that allowed us to manage chronic disease. And over the last 2 to 3 decades, we've had a strong push on social determinants of health. But even with our best intentions, a lot of our efforts have been incremental, which gets to Amanda and Mia's point. We haven't actually had the social mobilization around health, the reckoning around our values around health, the reckoning around our priorities for health. And that's what we're calling public health's 5th wave. And as you see efforts by foundations like the Robert Wood Johnson Foundation, as well as other organizations in this country, we're really trying to move beyond just a social determinants frame of thinking, but what is it going to take to actually value health and well-being in this country? And unfortunately, we're seeing that come to home to roost in the context of the triple pandemic. Next slide. And so, you know, as I look at the good intentions, the rhetoric, the narrative that certainly my field and the field of others has been pushing and advancing and articulating and motivating and catalyzing, I've been encouraged. And yet, as we look at the pandemic, the triple pandemic, but most assuredly the COVID-19 pandemic, we've exposed some areas of great weakness that are going to matter for health and well-being going forward. They're going to matter about health and equity. First of all, we continue to have deep challenges about our ability to really cohere around a common health action plan, not just a pandemic response plan, but a true plan for health. We still remain in this difficult place where we're dichotomizing whether you can prioritize your health or your ability to vote and civically act, or your health and the economy. We haven't yet cohered around a way of thinking about health across the sectors, even though we've committed to cross-sector collaboration and the importance of that. And we're also dealing with the harsh truths about our health values, including equity. Who do we value? What are our priorities? What are our issues around human rights? What are we saying about who we're allowing to die, who we're allowing to suffer? All of these are coming to bear, not only in the context of COVID-19, but certainly in the context of all the other intersecting pandemics that we've unfortunately been observing and borne witness to over the last 6 months. Next slide. And I raised this slide as an example of how far we need to go. So this comes from a survey that we periodically do between the RAND Corporation and the Robert Wood Johnson Foundation, where we've been tracking kind of where the public opinion, where the values are, where the community values are with respect to health. And because we're talking about solidarity for health and community cohesion and social connection, it's important to kind of recognize where we are when we ask the American public about the ability of their community to make positive change for health. And these are questions that were posed before the pandemic, and we're continuing to ask these questions during and after the pandemic. We've got a long way to go if we want to move to community connection and ability to advance health and well-being, as represented by just this snapshot from the survey that we conduct. Next slide. And so where has this promise failed? And I'm going to suggest that as we think about solidarity for health, as we think about health and democracy and civic engagement and policy and leadership, there are a few places where we're going to need a new health structure. And this time, a structure that sticks and move beyond some of the rhetoric and the conversations that we've been having individually by sector over the last several years. One is around this idea of generational health wealth, which I think speaks to the intersectionality around equity, but speaks to something deeper than that in terms of the accumulation of wealth, particularly in communities of color. A way of thinking about our values with respect to health and well-being, and not simply chronic care management markers or health deficit markers. And then a new awakening about who's responsible when it comes to health leadership and how we need to call each other to action in the next wave, this culture of health, this opportunity for potential and connection that we have as a result, unfortunately, of this pandemic. Next slide. And one of the things that many of us have been talking about, and I open it up for a broader dialogue, is this idea that when we go into communities, and often, unfortunately, we do it even with the best intentions within communities of color, within historically marginalized communities, we're often flying in and flying out in terms of an intervention that may be effective, a short-term policy opportunity. We're not really thinking about a lifespan approach about health investment over generations. And so the things that we often take for granted with respect to health begin to accumulate over the longer period of time. So when we talk about cumulative risk, cumulative stress, some of the distinguishing characteristics that we see now in this acute phase of the pandemic, we really have to think about how we're investing over generations with respect to not only addressing equity, but how we're thinking about the health assets and the health capital that we're leaving with communities in order to advance their own health and well-being going forward. Next slide. One of the things that's made the news over the last couple of days, if people noticed Nicholas Kristof's piece in the New York Times a couple of days ago, was a piece that reported on the recent findings from the Social Progress Index, which essentially showed that even with improvements in GDP over the last several years, and the US not being an exception to that, when it comes to social progress, when it comes to measures of health and well-being and health wealth, we are fundamentally falling flat, and not just falling short, we're declining. And so when we talk about things like diseases of despair, social isolation, mental health, community trauma, collective trauma, resilience, we are simply not where we need to be. This is an excerpt from some work that myself and my colleague Neil Halfin at UCLA have been working on, which is trying to think about ways that we actually measure progress in this country that's not just tied to GDP alone, gross domestic product, but is really tied to health wealth across the lifespan and human potential. When you start to put things in this developmental frame, as noted on this slide on the right, Then you start to have the tough conversations about where we're investing, how we're investing, and how we're thinking about equity. It starts to tie together things that are not simply about clinical care, but tying things to health that we know matter with respect to learning opportunities, economic opportunities, community connection opportunities, and the like. And we're not there yet in health and in the fields of public health specifically, but we could be as we think about human potential and connection and well-being and equity going forward. Next slide. One of the most important things is that we often have a lot of traps in our work when we talk about health. I just want to briefly mention these and for later discussion. We often still, even when we talk about integrated health and the balance of important things like the public health department and medical care and social determinants of health, we still do most of our work separate from community development. Now, schools of public health like UNC are doing tremendous jobs in educating the next generation of health leaders to understand economic development, municipal finance, community development. But as Mia rightly noted in her timeline slide, we have to also educate people and the future leadership around the trajectory of community development, the historical context of community development. And we often miss the boat when we're crafting and designing policy in ways that are actually going to impede the accumulation of health. We often don't connect health to actually not only economic productivity, but to a generative economy, a creative economy, and social connection. We miss the conversation of how to do that, and we can do better. And I certainly won't take too much time on this, but I've always felt that Maslow's hierarchy of need, while initially potentially helpful, has actually been not helpful when we talk about health equity and the accumulation of health. Because at the top of that hierarchy of need is often things like civic power, self-actualization, and well-being. And often that's put out of the reach of some to the benefit of others. And so we need to think about some of our frameworks and our structures that we've long held on to and really reimagine them, criticize them in terms of where they have impeded our ability to think about health equity, solidarity for health, and accumulation of health. Next slide. You know, another piece of this is what we're measuring. What we measure, just like a budget, is tied to morality. It's tied to our investments. It's tied to our priorities. Next slide. You can go to the next slide. And one of the things that we don't measure very well are other indicators, assets, amenities, and conditions that actively promote well-being in communities. We're really good at looking at things like avoidable hospitalizations, and that's important. That's an important part of the picture. But we're not very good in terms of measuring governance and policies and community power and investments in communities that really do lend itself to that health wealth. The well-being of the environment and the planet, all things that intersect when we talk about equity and health. And so how do we start thinking about measures of thriving and flourishing and optimization and productivity with respect to health? And there are a lot of conversations that are moving in that direction. I'm just suggesting that we need to move more quickly. Next slide. And of course, we're seeing this represented in efforts not only in the US, but also efforts nationally, globally, and in some of our peer countries. So things like the Sustainable Development Goals, New Zealand having its first well-being budget, are opportunities for the US to really take a page and say, how do we start thinking about the connections of well-being, health, and health equity? How do we power that through our budgets, the dollars, to Amanda's point, the policy levers, to Amanda and Mia's point, and to our choices. And I've had the privilege of working with cities like Santa Monica in California that actually tied well-being measures to their policies and their budgets. Next slide. And then finally, we've got to think about the leadership. First of all, as we see in the COVID-19 pandemic, we've got opportunities and we've got challenges in terms of explaining the importance of health. And we've got to start thinking about the path of how health is our ability to connect with others. Without health, we have nothing, and we see that today. that health is tied to those societal outcomes, not just something that, oh, the public health department does in a community, gets called to the show for things like COVID-19 and then goes to the side in terms of community discussions. We have to be central in those. And that health is every day. The investments that we make in health are every day. They're not in the 20 minutes that we might see a primary care provider, although important. Health is in everything that we do in our social, structural, and political environment. And we need to be sharper about those messages. Next slide. We also need to think about leadership that can handle not only the triple pandemic that we see today, but this idea of cumulative health stress, the ability to work across sectors, the ability to have resilience-based leadership, the ability to handle that. That's going to be so central going forward, not just as we recover, hopefully well, from the pandemic, but how we recover equitably and how we don't trade one set of problems that is plaguing us today in 2020 with a whole host of other problems in 2021 and 2022 and beyond. And leadership that understands how to design policy, think about the interdependencies, is going to be needed now more than ever. Next slide. We're also going to need leadership that comes from outside of our health research and policy alone. We're going to need the AMA, we're going to need the APHA, but we're also going to need the Business Roundtable. We're going to need corporate sector. We're going to need small business to think about this and really start tying this to not a one and done corporate social responsibility, but is central to the obligation of these other sectors to the health and well-being of our country going forward. And in that, we will start to see some of the movements that we need to have happen in terms of health equity. So I'll leave you with this. I started this with saying that we were moving in this direction. We were talking about health equity and health in all policies, and we were making important public statements about racism as a public health issue. And yet when we look at the response and our ability to attend to what has been occurring over the last 6 months, I think it raises really important questions that we can't just have a Band-Aid or incremental approach in how we're thinking about health equity going forward and health and well-being. We have to make good on this health promise, or we will be back here again and we will backslide, as was noted in Amanda and Mia's excellent presentations. Thank you.
Well, thank you very much, Anita. We have a lot of difficult truths to deal with when it comes to our health values, and including equity. I like your term, health wealth. It may not be your term, but that's probably one of my first times hearing it and hearing it explained so well. So thank you very much. Well, we don't have that much time for our questions and answers, but we're gonna take a stab at it. Also, thanks to our other presenters. And what I'm going to try to do is actually sort of combine some of the questions. One that actually came up in different ways. People just want to know, there are a lot of young folks out there, and they really want to know, how does a person who's really interested in being a voice for community change find other persons and groups to do so? And also, I guess, how to actually, you know, help college students per se actually become more interested in getting the word out. And I guess maybe that's a question for Mia.
I'm so really encouraged that that's the question, right? Because I do recall being in college not very long ago, but long enough ago to remember my own struggles with trying to balance my very heavy academic load, and then also honoring that part of me that wanted to be not just civically engaged for the moment, but deciding that across my lifetime, my work's work was also going to be outside of the organizations that I was obligated to be a part of, right? So I would first and foremost make sure that always you're doing your reading, right? I know that doesn't necessarily get at the heart of the question just yet, but read everything you can get your hands on certain subjects. And then within your relationships, right? Because that's really the site of serious change, is within your relationships. Talk about the things that you've read. Address questions that you might have, bring it up, be okay with, and get really comfortable with having uncomfortable conversations. Once you're able to master that, then I would also encourage you, and maybe even simultaneously encourage you, to reach out to those organizations that are on your campus that have a history of working with non-traditional partners outside of the university, right? And by then, what you would want to do is posture yourself as someone who is a burgeoning leader in your space, and I would encourage you to just go and attend meetings with, with people who have long-standing rapport in communities that you're interested in furthering impact, and just listen, right? Listen, go back to the things that you've been reading, go back to the conversations you've been having with the people with whom you've established relationships, and then eventually it will become very evident to you where you can get in, right? Where you would fit in, and where your leadership will essentially call to you where you need to be. But in terms of creating spaces, there are spaces already there. You just have to be really intentional about wanting to do the work and show up, and listen, and come with a heart of humility, and understand that no problem is too big for you to do something great.
Well, thank you very much. This question may be, I guess, for Anita. How do you see payer utilization management strategies like copay maximizes and copay accumulators affecting healthcare for people of color, and I guess access to treatments?
Yeah, so if I'm understanding correctly, thinking about kind of payment models and
Right.
payment reform, and one of the things that I know that a lot of healthcare systems are trying to do is track clinical social factors as it relates to health, and that's an important piece of capturing things like social prescribing and the like, in terms of addressing the needs of populations that may have inequitable access to those services and resources. But in terms of kind of structuring payment systems, the question is in terms of pay for performance and the like, what are providers on the hook for? What are health systems on the hook for with respect to addressing health equity issues, and not just simply kind of closing gaps in terms of disease management outcomes? And to what extent is that reflected in patient payment models versus kind of pay for performance provider models? I'm not sure if that's really getting at what you're talking about, but I do know that a lot of health systems are really grappling with two things. One is how to capture population health in bundle payment and payment models. And number two, how to think about return on investment in terms of individual and community health outcomes. And then what does that then look like for financing schemes in terms of health systems and their relationship with the surrounding community? But one of the challenges is that we're doing a lot more of clinical screening of social factors. Do you have access to housing? Things like that. But to what extent, and what is the threshold for health systems in terms of broader health equity outcomes, and how that gets reflected in financing? And for that, I think there's a lot of room to grow and develop some ideas in that space as health systems really struggle with that piece of their role versus contributing to a larger conversation around health equity.
I would think that would be at the top of a lot of lists, especially at a time when so many people are actually, paying a lot for their health insurance, and they almost can't even see a doctor now. I mean, the times have actually just turned the tables on healthcare, and not just those who have access, even people who thought they had access. Some are saying they feel they don't have the access that they need right now. So that's, I think, will be a very important issue. Amanda, I see a question. Someone's wondering, how does the field of public health plan to increase the public's trust? I've seen several surveys of late, especially as we talk about the disproportionate number of people of color who are affected by the coronavirus and COVID-19. And when you ask them, do they think, one question I remember distinctly, if there is a vaccine, anytime soon for COVID-19, do you think Black people, will be some of the first to even get the vaccine? Or it was flipped in a way, who will be the first to get the vaccine? And many people of color taking part in this survey clearly felt that they still do not trust the healthcare system, and they don't even think that they would even be given the vaccine if there's not enough. I mean, it's quite startling that people actually feel that way today. So Amanda, about trust, what are we going to do about that?
Good question. And I don't think necessarily an easy one to answer, but I think first is just to acknowledge what has led to the mistrust. I will just say early on in my public health career, when I had to go out into communities and as a public health researcher, do surveys and focus groups. And, one of the biggest lessons, even as a woman of color, was when I walked in, people saw me not just as Amanda Navarro, but as this person representing X academic institution. And that academic institution has a horrible track record of extracting and really harming the communities of color surrounding that university, and not having a good reputation because of it, because of the extraction in medical and research studies. So, that was really a place where I really had to understand that even as an individual, I was representing an institution. And so my work had to be both about acknowledging that past that institution had created, and also a responsibility to first and foremost begin to build trust, and that takes time. So that really meant me letting go of any agenda, any task that I needed to get done, because that was really just the place where I needed to rebuild trust with community. And I had to also be allowed to be held accountable by that community to say, okay, if we do this with you, you have to follow up. How are we going to lead? How do we own the data? Make sure that what you're doing with it is for us to have the power to do something about it. So that is the work in building trust, and know that when that's not there, everything else gets put aside, but it's really first and foremost taking the time to build relationships and rebuild that trust. And that comes with acknowledging the past.
Right. Many have said that we haven't had a truth and reconciliation gathering of some sort like South Africa did many years ago. And until that time comes, there has to be a true reckoning of the past. So the next question, I would like to maybe toss at Anita. Someone is asking, how can we hold hospitals accountable for health equity, internal healthcare disparities, both at a local and national level? And is there talk of implementing standard measures of equity?
Yeah, it's a great question. Well, I think there is some ongoing conversation around health equity measurement, what we're really measuring, what we need to be measuring. There are efforts to measure equity in communities and city level equity indicators and the like. One of the challenges with those equity indicators is they still tend to be focused on health disparities, and that's not a fulsome story around equity. We're really talking about measuring health equity in terms of both process and outcomes. If we're talking about upstream drivers of health equity, then we need to start measuring things like power and governance and structure and structural racism and the like, as it relates to equity and health equity specifically. And for that, I think there are some conversations, I've been part of some of them and privileged to be so, but we're not where we need to be yet in terms of true equity measurement. So that's number one. In terms of hospitals, I think the real conversation is what is the role of hospitals in the larger health system? And so, first and foremost, hospitals are not the only ones on the hook for health equity, nor should they be. They're a piece of a system for health. And number two, how do we start thinking about their collaborations with organizations outside of the hospital or healthcare system, and those organizations that are really on the front lines of some of the aspects of political and social and structural determinants that I think all of us have been talking about in our presentation. And so even before we get to some of those measurement pieces, rebalancing how hospitals sit at the table in a conversation about a system for health and well-being and equity is going to be absolutely essential.
Thank you very much. I think we only have time for one more question. And Mia, I don't even know if this is a proper question or if it's just, I don't know, too big, but is it ethical to quickly push through to authorize, let's say, or approve a coronavirus vaccine right now? And there's much talk about that nationally. And, if it's time to push it through fast now, or should we wait until enough tests are done, enough people are tested, and we have the valid research out there to actually try to stop this pandemic?
Yeah, that is such a big question there. And I feel like, Leonida, we would need an entire forum to unpack that. But I think that there's some points to be cognizant of. There are two that come to mind. One, we have to lead with the science, right? The science does have to be there, and the science itself is new. It's not anything that we are able to with long-standing confidence say that what's happening, in terms of development, we know all the outcomes. We don't have time on our side for that. But the moment really does require that our developers are paying attention to some of the really very critical elements of vaccine, not just development, but distribution, and really getting at some of the hesitancy points, right? There's an incredible sense of mistrust and distrust, right? That even if, a vaccine were perfect and it were available tomorrow, we would still have to deal with, right? And in that way, it's less of a scientific approach with respect to vaccine, and it becomes then a conversation around community rapport building. It becomes a conversation around investing in campaigns to really help push the conversation around health literacy. It becomes a conversation of offering these communities that are on the ground resources such that they can, in a culturally competent, structurally competent way, convey conversations and messages to those communities that historically will not come and willingly, right, for vaccines. So do we need to do it quickly? If doing it quickly means that we miss the mark in terms of all those equitable considerations, then that will do more harm than anything, right? But do we need something? We do. But the larger need is understanding that if we don't have also within the design pipeline those other points, which is, health literacy considerations, structural competency considerations, rapport building, and getting at hesitancy, the root of it being mistrust and distrust, and several other things, and we're not, then wellness is not necessarily going to be achieved.
Well, thank you very much. We'd like to wrap things up now, and I don't know, Amanda, do you have a short comment, closing remark that you'd like to make before we leave today?
Yeah, just one last thing to say, September 22nd is National Voter Registration Day. So if you are not registered to vote, register to vote, get your neighbors, your friends, your family, your colleagues to register to vote. get out the vote, start getting that out and volunteering. We need so many volunteers right now. So if that is one immediate action to take, that's the one to take.
Thank you very much. Anita, any closing remarks for this group?
Well, I certainly second Amanda's point. You know, one of the things that I have been struck by, and people have been saying this for years, but it's always a good reminder, you know, the system is working exactly as it was intended. And so everything that we're doing, whether it's improving our system for health or our broader system of democracy, requires us to rethink and redesign. And so it's not enough to say, well, the system is failing. The system is quite frankly working as it was intended. And so it's on each of us to think differently about that system. And I encourage every one of us to start to think in disruptive and new and different ways from even the way that we were trained perhaps in public health and in health going forward.
Well, thank you very much. And Mia, your last goodbye today.
Yeah, I firmly believe and support both of what Anita and Amanda have offered. You know, if we could prescribe voting, then I'm sure we can get out all the scribbly pads and just start handing them out, you know. But the other thing is too, as we're doing this work, as you're doing this work, whether you're new in the space of equity or you're seasoned in it, I would absolutely say take care of yourself, take care of yourself, take care of yourself. Make sure that you're also a part of groups that hold you accountable for your self-care. And self-care can certainly look different ways, but there's some things that are universal. Stay hydrated, stay rested, and be okay with having with asking for grace in the spaces where you might need some time to work some things out. It's really difficult to work on these hard topics internal in organizations, and yet so much is going outside with respect to violence across racial lines, with respect to, of course, the pandemic. Some of you in the audience may have family members who have been affected directly by COVID-19. You may have lost loved ones, but maybe you're not sharing that with others. And so I hope that you are able to create spaces and find spaces of vulnerability and give yourself space and grace.
Well, thank you very much for those heartfelt remarks. Definitely a lot for us to think about. And we hope that you will continue this very productive discussion with our panelists next week during our Continue the Conversation series. Registration is free. It's an opportunity to take a deeper dive into the topics we discuss with each of our panelists. And feel free to invite your neighbors, your coworkers, your colleagues. The registration links are in the chat. And again, many thanks to all of our participants across the country. Your attendance, your questions and comments have made for a wonderful, compelling session, one that we hope inspires renewed action, leadership, and advocacy to create greater equity for all. Again, thank you very much. We ask that each of you check your emails to complete a brief survey. We'd like to hear from you about today's program and ideas for future webcasts. We thank each of you for joining us today. I'm Leonida Inge. Have a great autumn.